Dana will speak about her research group's endeavors to create medical and surgical technologies that are minimally or non-invasive to advance pediatric intervention and therapies. Our second speaker will be Hub van Hedel. Hub is a professor of neurorehabilitation, head of research, and member of the executive board of Swiss Children's Rehab of the University Children's Hospital in Zurich, in Switzerland. Hub will present how his group personalized rehabilitation technologies to the child's need, the expectation of different users from such technologies, and their limitations. The last speaker will be Luc de Witte. Luc is a professor of technology for healthcare at the Hague University of Applied Science in the Netherlands. Luc will provide you with a brief overview of how robots have been, are being, and can be used in the field of child health and healthcare, including clinical and medical application, but also social and educational applications. At the end, we will conclude with a question and answer section where the speakers will answer your questions. So please feel free to open your microphone at the end and ask for your question, or write the question as a text and I will read it for you. So now I leave the floor to our first speaker, Dana Damian. Thank you, Dana.
Thank you. Can you hear me well? Right. Well, thank you. It's really nice to be here. Thank you, Paul. Thank you, Amelia and Bonka, for inviting me. It's really a pleasure to be here with the other speakers, Luke and Hope. My talk today will be, as I understand, mostly focused on the surgery side of things when it comes to pediatric applications. So I'll kick off with sharing my slides. All right, so I hope you can see my slides now. Thank you. All right, just clean up the screen here. Right, so today I'm really delighted to speak to all the attendees and looking forward to our interaction later in this webinar. The work that I'm going to present today will be around soft implants and programmable capsules for the gastrointestinal tract. This is a work that we do in my lab, the Sheffield Biomedical Robotics at the University of Sheffield. So here is some images that depict a few decades of advancements in surgery. All of these will have been propulsed in order to reduce the patient trauma, to accelerate the patient recovery, and to increase the efficacy of the treatment. In my lab, we work along the same aims, what the paradigm that we embrace in my lab is to develop technology that delivers surgery from inside the body. So when we speak about reducing the patient trauma, we are obviously thinking about minimally invasive surgeries or ideally non-invasive surgeries. We are also thinking about technology miniaturization, and this comes really as an important factor, especially for the pediatric patients. When we speak about increasing the efficacy of the treatment, we think that what is important, apart from the actual repair of the tissue, is to be able to sense in real time the site of the treatment, what the tissue state is and how it changes over the duration of the treatment. Also to be able to deliver a controlled therapy, and also to be able to have this kind of capabilities throughout the treatment. So that is beyond the surgical theater and the few occasional visits to the hospital. So these are a few principles that we try to apply in our work. So here is a slide that kind of gives a peek into the type of the technology that we develop in my lab. I am not going to be able to describe all of these things. I will touch on a few examples of robotic implants and capsules today. So most of these technologies are, for us, an exploration of the classes of robotic implants and ingestible surgical robots. We have a few research tracks. One focuses on tissue robot intervention or interaction, and that is to investigate what is effective therapy. The underlying questions that we ask in my group is whether technology can provide personalized treatment and how can this be done? How can technology be a stealth technology, sort of fooling the inflammatory reaction in our bodies in order to focus and deliver an effective therapy. We also focus on robot intervention and how to make it seamless. And underlying questions here include, can this technology conduct some of the surgical tasks autonomously? Can the technology be self-contained? And I'll come to this later. And lastly, on robot homeostasis, this is a more technical branch of our research, which looks into how to develop resilient technology, which comes very important and has direct effect on the safety of the technology, especially when this has to reside inside the body of a patient. And so how can we make the medical devices resilient to breakage? How can they be self-sufficient? So the work that I'll present today really touch on these two questions mainly. Now, we started a few years ago, back when I worked at Boston Children's Hospital in the US, working on devices to treat long gap esophageal atresia. So this, at Boston Children's Hospital, there is a center of excellence for the treatment of long gap esophageal atresia, which mainly is a disease where patients are born with an incomplete esophagus. And what the current surgery consists of, and that the surgeons at Boston Children's Hospital are really among a few experts in the world. What they do is that they attach sutures to the ends of the esophageal stubs. Let me get my laser pointer. So they attach the sutures to the ends of the esophageal stubs. They loop around the ribs and they tie them off at the back of the baby. And then for every day, they would pull on these sutures in order to elongate the esophagus. So for me, it was pretty hard to figure out in this century how medieval, if I may say, at least from a perspective of an engineer, we could still deliver, this type of treatments. How they have superior results, and what the surgeons do is something really, really incredible. But it is the surgeons who basically knocked at the door of our labs, searching for better solutions because of the morbidity of this treatment. So during this treatment, babies are in intense care unit for a few weeks. They also spend hospitalized for a few months and under general anesthetic during the tensioning of the sutures. So with all this, I have collaborated with Pierre Dupont at the Boston Children's Hospital, and we came up with what we think could be a curative technology. We developed this robotic implant that attaches to the esophagus and gently applies tension on the esophagus. And all of this happens inside the chest of the patient. What we also have here is a number of sensors. We have sensors that detect the tensioning of the tissue, the displacement of the tissue during the stretch. And we also have a motor that can be controlled remotely. So we have access to the information every day and in real time from the sensors as to how the tissue is adapting and how the tissue is tensioned, as well as the possibility to adjust the stretch adaptively according to the state of the tissue every day, anytime. Now here in this video, I hope it plays for you well. You have a fluoroscopic imaging of the robotic implant as it's attached to the esophagus. Here, the esophagus is visualized using barium. So we basically applied about 2 millimeters of displacement every day for about 9 or 10 days. We were very excited at the end to see that we have had a growth of the stretched segment by 77% in just 9 days. This was also surprising for the surgeons that we worked with. And even more, there was a controversy or a big unknown as to why, clinically speaking, as they applied the usual long episurgical trachea treatment, why the esophagus elongates. Is it because of the cell proliferation, which is the outcome, the cause of the real growth of the tissue? Is it because of the hypertrophy? Is it because of the inflammatory response of the body? So our histological analysis actually showed that most of the growth have stemmed from the cell proliferation, the muscle cell proliferation, which are also the functional cells of the organ. So that gave us a lot of hope of what this technology can do. We also have seen some significant development of collagen, and what we measure to be the ratio of muscle cells proliferation to collagen formation was 63% to 37%. So these results propulsed the research work in my lab for the past few years. And based on these results, we have developed soft implants for the growth of esophagus and of short bowel. We extended it to short bowel syndrome. Now, why we developed or we transformed this implant to a fully soft one is because of a hypothesis of based on finding in material engineering, saying that the compliance of mechanical devices to the stiffness of the target tissue would reduce the inflammation. So we are basing our development of new technology on this assumption in order to basically reduce the inflammatory response and therefore to maximize the functionality of the new tissue. This is a version of the soft implant attached to an ex vivo esophageal organ. And then we have another one inside a bowel tissue, which is hidden to our view, obviously, but this is also because of the purpose as we are searching IP protection. Now, this year, we are hoping that the soft implant will be tested on animals. We are collaborating with Richard Lindley and Mark Linton from the Sheffield hospitals. And in a year from now, I should be able to show you more results on the effectiveness of the soft implant. Now, what I would like to tell you more about when it comes to soft implants is about the sensing part. And I stressed earlier why this is important. So we have developed a soft sensor that is biocompatible and is conductive based on saline. We want to be able to sense the displacement of the tissue and the force that is applied on the tissue, with the benefit of increasing the safety of this device and having the real-time monitoring and control. This type of sensor can be applied to a variety of applications, medical applications. It could be a catheter, if you will, but it also can be used at the tip of a probe, or of course, in the case of our robotic implants. So the work principle is shown in this slide. It is the building block is a membrane that inflates. in which we pressurize this ionic conductive liquid. And by reading the resistance of this conductive liquid, we can get a change in resistance that speaks about the displacement of this inflating balloon, of the force that is applied on the environment, such as the tissue. And by fusing these two types of information, we can also derive information on the stiffness of the tissue, which is a cue to its health. Here, what you can see in this video is experiments in which we varied the volume of the conductive liquid that we applied to the actuator, the sensor actuator, as well as a change in the concentration of the sodium chloride. And this leads to some obvious changes in the resistance. We characterize this sensor, and I'm not going to go in detail through the plots that you see here. What I'm going to say is that through thorough characterization, the soft sensor actuator showed a good displacement resolution of 1 millimeter. So that means that we can sense every change, every 1 millimeter change in the displacement or the inflation of the soft sensor actuator. And we can also sense a force resolution of 25 grams. Now, to show you a flavor of the type of applications for this soft sensor actuator, we have placed the sensor at the tip of a probe that was indented into a block of gelatin that represented tissue of differing stiffnesses. And as we see in this plot, we could read forces and heights, or inflation of the inflating membrane. And the predictions of the force and height were in reasonable agreement to the solid truth that is in solid lines. For the soft, I need to mention this one was mostly efficient for soft tissues, but that's what we are looking for. Also, we have placed the soft sensor actuator at the tip of the soft implant. As you have seen in the rigid robotic implant, what we were looking to know, to read from our sensors is the displacement and the tension. This is what we are doing here. This signals show the force readings and the height readings. And so this is the type of information that we want to have in order to understand the state of the tissue before we apply any tension. So my group believes that soft matter devices, so devices that are made out of soft materials, will play an important role in medical technology for a number of reasons. One is because this softness complies with the softness of the tissues that we have in our bodies. Also because the fabrication and the design can be really customized to the clinical requirements that we need to fulfill. But one of the drawbacks that we have experienced is the fact that whenever we develop such soft implant that is based on fluids, so we use fluids in order to activate it, this has to come with a few gears, as you can see in this picture. So here in green, there is one of representative soft implants that we developed in our lab. But in order to actuate this, to inflate, you can see the soft implant really like a more complex set of catheters. But in order to actuate it, we need all of these things. We need tubings that make the fluid circulate towards the implant. We need valves that turn on or turn off the circulation. We need the pumps that pressurize the air or the fluid. Then we need these valves being controlled by microcontrollers that turn them on or off. And eventually we need the power cord. And this is really because the classical fluidic devices work by transforming the electrical energy into fluidic energy. So in my lab, we've been asking ourselves how we can advance this technology such that it does not have to come with a complex system around it. I know that surgeons are pretty used to complex systems, and I'm always impressed with how they can hack the body and work with all type of complex technology that we deliver to them. But as a technologist, I do want to see that we provide them more accessible and more intuitive and simpler devices that they can work with. So what we have looked into doing is to understand how these medical robots can be more self-contained and how we can use in situ energy rather than energy that comes from outside of the body, using all of these kind of cablings. So this kind of question has propulsed a lot of the research in my group, and research including capsules for surgical tasks. So this type of research in my lab started in 2015 with a collaboration with Dr. Shuhei Miyashita at the University of Sheffield and Daniela Rus from MIT. We have started asking ourselves whether we can develop a surgeon quite ambitious that can be in a way swallowed, and once it's inside the body, the little robot can do a few basic surgical tasks. One of our first work was to use origami principles because through origami we can basically fold so to the extent that that robot can be encompassed into a capsule. And once the capsule is swallowed and arrives into the stomach, the capsule melts and it will unfold the robot to a 3D configuration. We need the robot to be to have a decent size in order to produce a working range of forces. Now, the key energy here comes from the fact that we have a little magnet on this origami patch. And with this magnet, we can actually stir the robot in any kind of direction using a set of electromagnetic coils that stays outside of the body. We've done a lot of work on how to control these little magnetic devices inside the body, also localizing where the devices are while they are moving inside the body. And in a variety of forms, here is a origami robot, here is a degradable patch, and all sorts of other capsules. I should be able to run this video. To show you how this capsule works. This capsule in particular, we have used it in order to drag out accidentally swallowed batteries, as well as to patch a wound and to deliver drugs at a specific wound site. All right. Now, I would like to move on to a more recent work in my lab on chemically powered capsule for tissue dilation. Here, our aim was to develop a capsule that navigates to the site of a stricture and then pushes away the stricture in order to restore the gastrointestinal tract. Now, discussing with various surgeons, this is a more complex problem that our technology can resolve, but take this as the first preliminary stages of such a device development. So first off, the capsule will need to navigate through the gastrointestinal tract and arrive at the stricture site. It will need to inflate in order to push away the stricture. And then upon deflation, it will go along the gastrointestinal tract to exit. So this development basically projected into a technical challenge of how to control the inflation of the capsule. So we have opted for using a chemical reaction that generates gas in order to inflate the capsule. Now, how to control the chemical reaction was the main challenge for us. The way we did it was, first we stored the two reactants, which are the two biocompatible reactants, sodium chloride and citric acid. We stored them into gelatin rings so they don't mix up spontaneously. And then after we navigate the capsule to the site of the stricture, what we do is that we try to make these two reactants combine. What we use is induction heating by making use again of the external electromagnetic coils and producing an induction heating. This is similar to what you might have in your stove at home. So basically, once the induction heating is applied, is activated, any kind of metal objects at a certain distance from the electromagnetic coils is going to warm up. So we have a small copper sheet inside the capsule, and when the induction heating is turned on, this copper sheet is going to warm up. This is going to warm up the water inside the capsule, and thus is going to melt the gelatin rings, making the two reactants combine and thus producing the gas necessary to inflate the capsule. Naturally, after a while, this capsule is going to deflate as the CO2 gas gets reabsorbed into water. Right, so here what I want to show you in this slide is the capsule navigation. We have tested the navigation inside a bowel tissue model using our in-lab electromagnetic coils. In the pictures in the middle of the slide, we have shown navigation inside bowel tissue. Now this is far more challenging, and one of the challenges is the miniaturization, or the size of the capsule. But the good news is that given there are no electronics in this capsule, the miniaturization is straightforward. Lastly, we also tested the navigation with an Ancon AKC1 inside a model of a stomach. As for the inflation, we have looked into a number of variables such as the temperature, being room temperature or body temperature, and what we have found out is that the capsule can dilate 60% at body temperature with 30 minutes induction heating applied. We have also showed the capsule anchoring into the bowel tissue, and the anchoring force has been close to 0.27 newtons. And some tests here showed how we can use the capsule to expand the tissue, creating workspace so that we can have surgical tools going into the gastrointestinal tract. Now, I would like to close my presentation today by summarizing the mission that we have in our group. One is to advance healthcare by developing non-invasive interventions and also developing tissue-responsive therapies. But also the other end is on the advancement of technology itself in order to make it more resilient, more fold resilient, self-contained, and self-sustaining. I dedicate this slide to my lab members who are doing the hard work and to the sponsors. I also want to thank the audience today. I'm very keen if you have any questions, but also if you see any kind of collaborative opportunity, given the needs that you have clinically and whether the type of technology that we develop here could be useful for you. And before I go, I also want to show a bit of our work for children and educating children as we see them as future inventors. We have, well, my son and I really have published a couple of children's books where we talk about robots inspired by the research we do in my group. And also my research group has also developed research-inspired children games that we take in schools, as well as we provide school robot demos, all to educate the future generation of engineers. So thank you very much for being here today, and I'm open to your questions later after the other colleagues will speak today. Thank you.
Thank you, Dana. You will answer the question at the end of the presentation of the other speakers. I ask Hub to start your presentation.
Yes, I will try. Okay. So I hope you see my presentation now. I would like to thank the organizers for inviting me to this online meeting. It's something interesting to do. Sitting here in your desk, hearing your collaborators running around in the clinic, and still trying to focus now on this talk. So I would like to invite you to another environment. I would like to invite you to pediatric rehabilitation. And my talk is a bit on personalizing motor rehabilitation technologies to the child's needs. So we are located here in the rehabilitation center that belongs to the University Children's Hospital. This is actually one of the largest children's hospitals in Switzerland. It has, of course, all the interest that you have with these university hospitals, so the treatment of patients, education and research, and it includes all kinds of specialties. For us here, our rehabilitation clinic is located about 30 kilometers outside of Zurich. You see it a bit here. It's a bit a nice green countryside, at least when it's not so cold and when it's not raining. We are actually the only inpatient rehabilitation clinic for children and adolescents in Switzerland. And this already shows you that it's quite a bit of a rare facility here in our country. Like all the adults, or also, of course, also the foreign rehabilitation centers, we provide a multidisciplinary treatment approach. And of course, we have our physicians and nurses 24/7 available. And besides that, we provide, of course, this big multidisciplinary intervention, including physiotherapy, occupational therapy, speech and language therapy, neuropsychology, psychology, sport therapists, and all kinds of things that you consider that children that require an intensive rehabilitation period need. We have a small outpatient care unit, and also here we have also different groups. And what I will show you later is also in these outpatient care, it is possible to combine these conventional therapies with also some technology parts. Now, for those working in our field, you know it, and others should be aware of it. We are not only treating the children, we always work with the family in total, and that can be very interesting. It can also sometimes be a challenge. Concerning the patients that we have, and this is interesting, but also a bit of the challenge. So these are some numbers from 2022. We had at that year 234 patients discharged during that, and on average, these patients were here for 41 days. But you can imagine that if you have a child initially being admitted after a severe traumatic brain injury, and as long as we can show that these children show progress over time, we have regularly the children or adolescents are here for over a year. Our patient group is very heterogeneous. You see that also a bit in the pictures below. Almost half of the children have cerebral palsy, so listed here as CP. We have also a lot of children with acquired brain lesion, like the traumatic brain injury, but also ischemic or hemorrhagic stroke or encephalitis and various other issues. Of course, for me here in research, that makes it really challenging, because nice, homogeneous, large groups to do research on, this is really something that you can forget when you work in our center. You also see the distribution of age. We really have babies from just a couple of months old up to young adults at the age of 18 up to 21 years. And what we should recognize is that, particularly during the last decade, I think the severity level of our patients increased tremendously. And it's now the case that it's not just that they have more physical impairments, but it's also that particularly the cognitive impairments become larger and larger. And this, of course, also has a major influence on the treatment that the therapists do on the motor behavior of the children. So this figure here at the right with this WFIM cognition actually shows that the average cognitive age, if I may say it like this, of the patients, that is, who have an average calendar age of about 10 years, it's more around 4 or 5 years. So you can imagine the large severity. The goal of our rehabilitation program, because these children, of course, can suffer from impairments in upper and lower extremities, trunk and whatever, the goal is always an overall goal to increase the independence and in the activities of daily life, and try to work as much as possible that these children can participate again in reality. For this, it's also that we have a school included in our center. So besides all the motor rehabilitation, these children also go to school here. What you can see on the slide here is that concerning the goals that the patient have, the rehabilitation goals, a lot of these are really focusing on motor behavior. So about 30% of the patients have goals to improve their walking and moving around. Again, about 30% in changing and maintaining body position, and about a quarter is focusing on self-care that obviously involves more the upper limb. So a broad range of impairments that the children and the families want to improve. Now, this nice countryside is a bit different as soon as you get into a center, because we've tried already for a long time. I'm here in the center since 2010, but they actually started already quite some years before, to complement the conventional interventions with technologies. So we have groups that are specialized in applying robotic technologies. For example, in my research and my small robotic team, we apply technologies like the Origo, the Locomat, or the Andago. These are all kinds of technologies to improve, well, the Origo is particularly to improve standing. Locomat and Andago are different devices to improve walking. We have a Ryzen technology integrated into our gait lab. We have a whole bunch of technologies that our occupational therapists favor. Always be careful, as soon as they have always the ideas to get new technologies that they can use to improve the treatment of their patients. And since a couple of years, we even have a high-tech leg press system and also a balance system that the sports therapists used in their regular therapy and training. I think what is very important, if you do a lot of work and particularly do research in this area, that we really should not forget that, yes, a lot of our patients, not all of them, but quite some, receive some means of robotic technology, some means of robotic therapy, but the most part is still the conventional therapies. And we think in general that there is quite some potential in these technologies, but there are, of course, always also some limitations why we cannot apply it to each child or for each goal. Now, before I move further, I first thought I'd talk a little bit shortly on definitions, what I actually mean with these technologies. And I think one important distinction that I would like to make is that on the one hand, you have rehabilitation therapy technologies and you have the assistive technologies. And for me, the rehabilitation therapy technologies, these are really the devices that therapists use to improve the function, that assist the patient in practicing to improve his function and try to recover. The assistive technologies, these can also include various kinds of technologies, sometimes even a bit more or less the same, but their purpose is rather to support the participants in their daily life, to improve their participation. We do not really expect that the function of the patients improves by using these technologies, but by using the technology, they are more independent in their daily life. And I do not know, I saw that there is quite a broad field of listeners here. If we look at the International Classification of Function and Disability in Health, the assistive technologies, they focus probably more on getting independent in activities of daily lives and improve this participation aspect, while our therapy technologies often focus on improving the body functions. Some other definitions are also, I work together with people from the technical university. I have engineers and informatics in my team, is that we call a robot always these devices that actually have some kinds of motors in it. But we also have various other systems that are not automatically a robotic device. So some devices have no drives in it, but for example, provide a certain amount of mechanical support, like the picture that you see in the middle here. This is a system that alleviates the weight of the arm of the child by having some springs included in the technology that actually lift the arm against gravity. So also children with less strength in their arm can move in three-dimensional space. And for those children who are a bit better again, who have more function, we like to apply the technologies without even any physical assistance. There is also, what is interesting is if you look at the shape of the technology, some of these devices have been designed to resemble the shape of the human body, and these are the so-called exoskeletons. They fit nicely around the extremities of the child. You see here some examples for the upper limb. On the left, you see the Pexo. It's a glove that that was developed by the ETH here in Zurich, and together we made it smaller to have it also fit on children. And on the right, you see a commercial device, the Amadeo of Tyromotion. Here you see that it's not really following the anatomy of the child, but you see that there are small magnets positioned on the fingertips, and the device can actually move the fingers and open and close the hand without actually that it's really covering the rest of the fingers. You see it perhaps a bit better on these examples of lower extremity robotic technologies. On the left, you see a already very old and relatively well-investigated device, the Locomat. This is an exoskeleton that had drives at the hip and a knee joint, and the child that walks in it is being supported by these drives. Meaning that of course, it takes a little bit of time to have this child being mounted into the device. But for those who have not so much muscle strength, the nice advantage of this exoskeleton is that it really supports the hip, the knee, and therefore also enables children with really almost no control of the knee joint, for example, to start using and start learning to walk again. On the right, you see a device that is here, again, an end effector. So the child is secured and body weight unloaded in the weight supporting system, but the only other connection with the technology is actually that the foot are strapped on these things. So it's actually the foot plates that make the movement of the child. And from a therapeutic point of view, you can start thinking on some of the consequences that these designs have. I will get back to that a bit later, but on the one hand, you see difference in practicability. So it takes more time to position the child in the exoskeleton than to mount it very quickly with these snowboard bindings on the end effector device. On the other hand, the child in the end effector device needs good control of its knee joints to be trained. And therefore, it will be more difficult to train a child who has less control of the knee joints, for example, in such a technology. And here we start to learn a little bit. So what kind of the design aspects of the technology might have actually an influence on the clinical decision-making of what kind of technology would you like to select for a certain child. We need to be aware that our patients, there are often children who have been born, for example, with a cerebral palsy, and what they have learned through life is that a lot of things that they'd like to try to do, unlike children that develop normally, it's more difficult for them. They have less success in their development. So these children with developmental disorders, they sometimes appear to be a bit less motivated and more passive in their playing behavior. Doesn't mean that they're not curious or they do not have fun on it, but the challenge in rehabilitation is always to try to go a step further, and this is something that is often difficult for them. And therefore, we think these technologies can be a very valuable asset, because what the therapist thinks, what they expect is that due to this combination with the extra gaming, you can actually make it very interesting and provide high dosage and intensity issues during this training. So, for example, in a study, so if a child walked 35 minutes in the Locomat, it can often achieve over 1,000 steps. Or if it's been training in this device that you've seen before, you will have several thousands of repetitions of hand opening and closing in a select number of therapy appointments. Of course, if you try to look at these technologies, there are also other stakeholders that play a role. The board is always interested to see innovation and often efficiency. To be honest, I see in adult neurorehabilitation that they use such technologies and actually try to have one therapist treat 2 patients at the same time. This is not possible in pediatrics, at least not if you want to do it correctly, I think. And research, particularly also of this device Locomat, has shown that, well, for the children, it's not actually always the technology that is the most important thing. Of course, they like to play these games. And of course, you see particularly the boys walking out of the room here after the training, and a new patient comes in and said, how many points did you score on that game? But at the end, what they really value is the social and the relational aspects with the therapist. And this is more important to them. One challenging stakeholder in this area are the parents, because they often have very, very high expectations when their child is using such a technology. Devices that cost so much, they must be really good. So they have really high expectations that the motor behavior of the child will be changed a lot. And it's always a bit difficult to in these interactions, because at the end it is the child that needs to make the improvements, and the robotic technology is not much more as a tool that the therapist has to do the training. Some other concerns when you introduce such technology is, of course, that you also need to have a short look at it from a technical point of view. And I just mentioned it shortly here, but there are various aspects. I always like to, I also did it for some of our studies, also like to use this model of clinical utility of Andrew Smart that was published already quite some time ago, but I think you can still use it quite nice. And that you have to make sure that your technology is, of course, appropriate, that it's relevant. If you use a new technology, you do not know whether it's really effective based on a lot of clinical studies, because often the technology is being sold before a lot of randomized controlled trials are being performed. But try to have a look at it from a clear view and see how it can impact your treatment process, or what can the technology do to fill in a gap in the treatment that you currently have. From a practical point of view, it's really important to look at the accessibility of the technology. All this technology that we have in our center, it's all third-party funded. To be honest, it's not my hobby to apply for all these foundations to ask for money for technology. So consider the cost and the cost effectiveness and the maintenance cost and the cost that it will get you throughout the time, and what will happen if it breaks down, or In case, for example, of one of our technologies, if you get an end-of-life situation and at the end you have to buy a completely new robotic device. For me, a very important point is the practicability. The worst technology that you can buy is the technology that the therapist doesn't use, because it's too complex, it takes too much time, it doesn't work. If a child starts to work with a technology and it breaks down 3 times, then the child is not motivated to work anymore with the technology and it wants something else. And finally, of course, also this acceptability issues that are both for clinicians, but of course also for patients and their families, a really important point. The question that I would like to see is that there is a reason why we have so many technologies, and that is simply the case because, like I tried to inform you already a little bit, is that you cannot really use one technology for all patients. And I'm sometimes being invited to discussions and I get very funny questions like, so do you think a Locomat improves a child better than an Armeo Spring? And I'm just asking, these are so strange questions to me, having a therapeutical background. So I think one really important question is how can we actually see what would be the best technology? And first, we should not forget that the therapist is the most versatile tool in training patients. The therapist can, after some training, can treat a baby of 3 months up to a severely affected adolescent of 16 years, from patients with major impairments to those who are close to doing interesting sports. And this is not the case with our technologies. You do not want somebody who is too good to train with a technology that supports him too much. And on the other hand, you cannot apply a technology to a person who is not able to use it. And I think this is the interesting question that I have, that we like to treat here in our research also with smaller scale studies, to find out what is the right patient, or on the other hand, what would be the right technology to apply to a certain patient, and what could work and what could not work. And this is a small test that I make with students actually from the ETH, and they're bright young people, but they've never seen patients before. And what I try with them is I show them a couple of videos and I ask them, so what do you think? What would such a technology be able to do? So I would take this small experiment and show you first a bit shortened video. If you would like to see more of these videos, you can look on our website. The first video is of the Amadeo. This is the device that you saw also at the beginning. You get little magnets being placed on your fingertips. Of course, you need to start up the program. You see the device is motorized, so it can train the patient actively. In therapist language, that means the patient is active, assistive, but also passively. That would be the engineer being active when the device performs the movement. You have some calibration issues. And what you can see, it's already a very dedicated device. It's only there actually to train finger movements, hand opening and closing. But as you already saw previously, you're being fixated in a manchet. So there's not a lot of other parts of the arm or body that you train. So if you start looking at it, it's a device that can provide active, assistive, or passive training. It's unilateral. And if you look at the joints that you can train, it's mainly on hand and fingers. Now, this device is the Armeo Spring. It's from another company. It's a bit of an exoskeleton. It's what you also saw in the beginning. It has these springs that provide weight support. The difficulty with an exoskeleton is that you always have to first adjust the size to the settings of the technology to the size of the child. And I apologize that some of the parts are in German. Again, here you can create some training programs that the therapist select to be in line with the target and the goals of the child. And you see here some smaller movements, but later you can also see that the child is really starting to work more in a 3D environment using the technology. So if you compare it to the previous device, the patient needs to be active, despite that there is some weight support. It's also unilateral. You have now almost all other joints, and there's only a bit of hand opening and closing that you can really train with the hand. So if you look at it, it's already only on this paper, you see that you can, the prerequisites are there to train to a completely different patient. Short third movie, that is Raphael, that's actually only a sort of a sensing system. You can detect.
Sorry, Hub, you have 2 more minutes.
Okay.
Thank you.
You have hand joint movements and finger movements. And you see here also that it goes up and down. And here again, you see that this system is less well thought of, training more proximal joints, but again, a bit better for the distal joints. Now, we have great occupational therapists, and what they've been doing in addition is that they start to analyze for all the games that each of these devices have, what kinds of goals you can train with them. And you do not need to look at this from the inside, but at the end, we get a great overview of what kind of possibilities there are to train what kind of devices with what kind of therapeutic goals, of active range of motion, passive range of motion, dosing movement, strength, or fine motor function. And we have made similar events like this one here also to deal for the lower extremity. And in our opinion, of course, the next step is then to challenge and test these models and see what you can only learn from the technology and what kind of patients you will be able to treat with it, whether you can really also see that then in the studies that you do. I have one important slide, and it is that these technologies are great. We can achieve a lot of them, a huge amount of repetition, but there are also still some limitations. So not each child can use the technologies. There's always the risk that children become passive in motorized devices. The screen time is high. Exit games are nice, but if a child is for several weeks in rehab, the games can become boring. And of course, not each goal can be trained. Think of that ICF. So my suggestion really is also be brave and have therapists explore these technologies, because a technology like this one that is actually only being used in the regular mode to train the shoulder joint, if you have some brave therapists, they can just change the concept of it, and they can really use it in other purposes, and also use it for this little girl where she actually trains all kinds of joints and all kinds of tasks. So my take-home message are really analyze the patient needs and impairments, and really analyze what you think the technology can really do. Ask others for their experiences, and consider the opinions of various stakeholders really when you try to select the technology that you think you need for such an environment. And it's really that I think that the technologies are tools for therapists. So give the therapist time to explore it. So I'd like to thank you all for listening, my team for all the many discussions that we have, and of course the families and also our funders. And I'm happy to give the word back to Emilia.
Thank you, Hub. Okay, now I leave the floor to Luke. Thank you.
Well, thanks. I'm going to find my presentation. Share. Where is it? It has gone. Come on. Share screen. There it is. Yes. Yep. Now you should be able to see my slides. Well, thanks a lot. I agree very much with one of the last slides of the previous speaker. saying that be brave and try these things out, because I think both presentations have presented the enormous breadth of this field and the huge wide possibilities in the very different application areas. And I will try to add a bit to that. Well, my name is Luc de Witte. I work at the University of Applied Sciences in the Netherlands, but I've also been a professor in Sheffield and before that in Maastricht University. So the past 20 years or so, I do research in looking at the potential of technology for health and social care. That's basically what I do wherever I've ever worked. I like the picture that I show you now very much, because it's a very old picture. If you hear discussions about robotics in healthcare, it's often you think that it is a very recent topic that's only becoming interesting now. But this photo is taken around 1985, when I started my research career in a rehabilitation research institute. And at that time, we were working on this robot manipulator, which can be mounted on an electrical wheelchair. And as you see, these two brothers both have breathing support, have a neuromuscular disease. And this photo shows a lot. It shows that robotics are not new. They have been around for many, many years. It's not only technology, it's not only training, it's also fun for life, because what these boys do, they have a beer together. And these are boys that normally would need a 24-hour presence of someone else, because they can't do anything. If a fly lands on their head, someone has to do something. Well, a fly maybe not, but if it's a bee or a wasp, it becomes already tricky. That's why I like this photo so much. It demonstrates the field, but it also immediately demonstrates that it is a very long road from inventing technologies and applying it and making it widespread. Because if you enter a regular, normal rehabilitation center, not the one we just heard about in Zurich, but a normal rehabilitation, you won't find these things. Certainly not at the extent that we have just seen. And if you enter a normal hospital or a nursing home, I do quite a bit of research in elderly care, it's not current practice at all. It's still very much in specialized centers related to research. So, well, that's an introduction. What I wanted to do is very briefly say what is a robot, just a few words. But what can robots do in health and social care? I will give a few examples of how they can be used, very different examples from what we have seen so far, and then say a few words about how I think this field will develop, because as the photo also demonstrates, I've been involved with robotic research since the beginning of my career in 1985 when I entered that institute. Come on, next, where do you go? What is a robot? Very briefly, a robot is not what you see on this photo. This is what most people think, a big humanoid metal thing, but that has little to do with robots. But it has some characteristics that are important. Robots have some way of sensing. They have to be able to sense their environment. They need some actuators. It has to be able to do something. It has to be at a certain level intelligent, autonomous. There has to be an embodiment. There's a lot of discussion whether an avatar, for example, is a robot. Well, I tend to think you should be able to touch it to make it real, and it has to be able to move or to exert some force. These are just very basic principles. What we often see, the order of the slides is wrong, doesn't matter. So what makes robots so interesting is that they have some very specific characteristics that are important. They can do stuff. They have some force, even if that's very tiny force, as Dana demonstrated. That force is essential. The most important thing is that it never gets tired. It can do repetitive tasks, and especially for training purposes, that's extremely important. It can do it 24 hours a day, as long as there is power. And it can deliver impersonal assistance in many cases. And so in that way you can ensure that there is always some level of care available. Especially robots that are built these days are intelligent, and I will in the end tell something about a really impressive thing I'm working on right now with Korean colleagues. Well, robots can be personalized, can be customizable, programmable, and in many cases, especially when you use them in a living environment, they can be integrated, embedded in smart environments. It's not only the robot, but the robot also knows where it is and can communicate with other devices and other technologies in a house, for example. These are some characteristics that make them so interesting also for healthcare. This is the typical view many people have of robots. And as I said in the beginning, this is not what robots are. This is how we tend to think about robots. So don't take this too serious. But it shows that there is a huge variety already in our views and our thinking about robots. Thinking about what you can do with this kind of technology in healthcare, then there is really a lot, very, very different applications. Dana has shown very impressive and sometimes a little bit scary applications inside the body, and it can do magnificent things. If you see these videos, the unfoldable things that do stuff in your body, well, that's amazing. And because now we don't have to cut people open. So that's one area. The surgical robots who do magnificent work, the therapy robots, the rehabilitation robots. That's what we have seen. But there's much more that can be done. I think at this moment the biggest field of research, also in relation to children and child health, is in social robots. Robots that play a kind of social role, are a buddy for a playmate for children, and also can perform some monitoring tasks, measuring all kinds of parameters of health. So just a few types of roles that a robot can take is nursing tasks. Now, there are examples of robots carrying people and helping making beds, bringing around medication, all kinds of different nursing related tasks can be done by robots. Companionship, also in elderly care, that is, I think, by far the most used at the moment, where the robot is just your friend, a mate. Robots that can deliver physical assistance, do things for you, help you put on your pressure stockings, and help you dress. I recently saw a quite impressive example of a robot system that helps people dress autonomously. You put on your sweater and put on your coat, which was in a way funny to see, but it did really work. Well, surgical and therapeutic applications that they already mentioned before I started. Training, rehabilitation, excellently covered in the previous talk. Robots that do monitoring tasks, that can monitor behavior, identify falls mostly in older people, all kinds of tasks looking after people, also children, of course. There's a very interesting branch is robots that support people in their day structure, not only in older people with dementia, but also in children with intellectual disabilities, developmental disorders, to help them just structure their everyday life pattern, and reminding them of that they have to go to school or to eat or to do certain tasks. And robots can be a kind of intermediary in the communication. So if you think about and look at examples, it's really the sky is the limit. There are so many different applications. This is just with a wet finger and not really with lots of figures. But if I look at this field, and I think I pretty good overview, then I dare to say that in all these possible application types I mentioned, there are examples, and there are very promising examples. Most examples that I know of research in the robotics field are promising. There is very little strong evidence, as Hugo also mentioned, but many of these applications, if you see the results, wow, this is really interesting, and asks for more. And there is a very strong emphasis. I think the most successful field at the moment is that of social robots, companionship, communication, teaching assistants, and they're used in classrooms to support children with special needs, robots for play, leisure activities, training, and support for all kinds of activities, day structure. That's the area where I see most research projects. Some of my PhD students have done inventories of this field and found really hundreds of projects in Europe alone. But if you go into practice, you hardly see any of these. So it is really still a very much a research field with small applications. There are some industrial or commercially available products, but they don't have big markets. It's all small. And many of the companies don't really survive for long. I just want to go a little bit more detail of 3 examples, really just examples of research I've been involved in. This is one of the most impressive examples. It's an English product. It's the Caspar robot. You can debate whether it's really a robot because it has to be operated partly. It's a semi-autonomous. And it is developed to communicate with children with severe autism. For these children, they are it's very difficult and scary to communicate because we have all these facial expressions and all these things that they don't understand. That's why this robot looks quite scary. It has no facial expression, and it can't move its face. So the face is always as it is. And it appears that this is a very important thing for children with autism, because many children think, well, it's a scary thing, but children with autism feel comfortable. And they feel comfortable about the fact that the robot is predictable, does exactly the same thing every time. There is a lot of material you can find on the internet if you look for YouTube films. There is a lot out there that shows the potential of this robot. And one of my PhD students did a very in-depth study following a few children for a long period. And there's also a very nice film that won a prize even, made by a television company about the relationship a child has with this robot over a year period. And there's one movie, short film, that I always still angry that I cannot show it because the parents gave me no permission. But it's the most impressive example I've ever seen of a robot. These were parents of a child who were watching an experiment where the child played with another child and the robot. And it was the first time ever that they saw their child play with another child. And the parents were crying in the corner because how is this possible? And it was possible because it was not a direct interaction, but an indirect interaction with the robot as the intermediary. And the robot did those things and that was really, really an impressive example of the potential, where maybe someone else would say, stupid thing. But in that situation, it was so powerful. And we have seen many of these examples. In that film I mentioned, in the end, the child, it's a little boy that you see there, asks the robot whether he would marry him. And that was real. And why is this so successful? Because it's predictable, it is safe, it is simple, it always reacts the same. For example, it was used in training a child not to hurt someone else. If the child squeezed the robot too hard, it would say, "Hey, that hurts," and it says that exactly the same way 1,000 times. And in the end, the child, okay, wow, this hurts. Just examples, but this is one of the really fascinating examples that where the effect was way beyond my expectations. This is a quite older example of robots used for play, to play for children who cannot play normally. For example, a child wheelchair bound with very limited ability to handle objects. And with this robot, you can play simple child games. How you call it, hide and seek, and it can run after you, or you can try to catch it, and then it runs away because of the sensor systems. It can position itself, and in this example, the photos, we asked the children to dress it like the way they would like it. And this was also a very, very successful application in a children's rehabilitation center to stimulate individual, but also group play. So these are already, this study, I think, is more than 10 years ago. I think 12 years ago that we already did this. And again, I show you that to show that it's not new. There's still a lot of research needed, but the potential is so obvious. The third application is quite recent. That is also done with EPTRI as one of the researchers. It was done in the Children's Hospital in Sheffield by one of our PhD students, and she looked at the potential of using robots to do something about anxiety of children who are admitted to a children's hospital. You can imagine that it's a scary environment. Many children will be anxious and have all kinds of stressful experiences. And the question is that can a robot help to release that, to reduce that stress and inform them? And again, quite promising results. The student did research in 5 different locations in the hospital, carefully chosen, the results are really such that you would say, well, this requires a follow-up. We need to do more research in this direction because it really looks promising. Just examples, and there are many more examples. So these are just very, very different applications. Robots carrying people, the very famous seal robots, the Pyro seal is quite successful. They now can play all kinds of games, arm support system, just random examples. So if you look at this, and that's my main message, there is really a massive amount of research and development in this field. And if you look at the most recent developments, it's very obvious that robots are becoming much smarter in a very rapid way. They become more adaptable. They are able now to recognize people, to adapt their behavior to persons, to respond to specific situations. They're able to recognize emotions. They learn faster. And they can be connected to the environment. And if you look at the potential of large language models in the AI models, then, well, there is so much is possible. I'm very, about a year now, I'm working with a Korean company who have developed the Hyodol robot. It's a puppet looking like a child, and it's HYODOL, Hyodol. You can easily find it. It's developed for dementia care, but there's a lot of response from childcare as well, and from people with intellectual disabilities. And we are looking at the potential, because it's a Korean robot that only speaks Korean, but what it has is it has built-in ChatGPT, so you can really talk with it, and it can give you answers, real-time answers, intelligence answers. I saw it yesterday morning, and I was, again, totally impressed what this technology can do. You can just ask, what will be the weather this week? And it gives an answer in Korean, but And in the meantime, that same robot has a lot of sensors. It can monitor your behavior. It can monitor temperature. It can monitor your activity, and initiate after 2 hours inactivity. Say, well, shouldn't we do something? Aren't you bored? So that is really the kind of development I foresee, that these things become really more interactive, proactive, responsive to their environment. And that opens up applications in information provision, in education support, in companionship, just friendships, between brackets, monitoring tasks, supporting day structure, remote care, social contacts, etc. So my last sentence would be very much like Huub said, go for it. Embrace this field, because it's happening anyway. They are coming. I've been in this field for about 20 years now, and 20 years ago, when I did my inaugural lecture, when I became a professor in Maastricht, I said robots are coming to care, and many people were angry and said, no, this is never going to happen. But it is happening, and I would say embrace it and make sure that we get the best out of it. Lots to do, but a huge potential. Well, that's it. Thanks.
Thank you, Luc. Thank you very much. Thank you. I would like to thank you all the three great speakers, and I ask the audience if you have some questions, or if you want to open your microphone. Okay, Paul, I see your raised hand. We don't hear you, Paul. Paul.
Can you hear me now? Great.
Yeah, perfect.
Even in a technology presentation, I've not managed to overcome the simple unmute button. So thank you very much to everybody for their presentations. They were really fantastic. It was great to hear about all the progress that's been made in the field, and some fantastic work going on in a number of centres around the world. My question is really about the translation of technologies into community and home environment, because this is potentially challenging. When you look at some of the kit, it's expensive, or it's large, and people are not necessarily living in large homes anymore. They're living in apartments. Moving around is quite challenging. So do you think that from a perspective of social robots, that their place is more industrial and health, and actually that it will stop at the point of being able to translate into homes, or do you think there's an opportunity to translate in the future?
Well, if that's a question to me, I think the robots will enter our lives, our direct life environments. They will become part of our everyday lives, and maybe even easier than aesthetics. My experience in some projects is that it is easier to convince parents, for example, to start using robots than to convince doctors and nurses to do it. So I don't think this is really the biggest issue. The issue, of course, is funding. Is it affordable? Is it safe? Also, kind of privacy issues. But these can be solved, I think.
If I can add to this, yeah, so translation is really important. I do think though that robots like social care robots and even the rehab ones can be our entry to developing more, let's say, safer and trustable robots. I think we have to develop a lot of trustful development, robots, in order for the regulatory entities to get a better sort of grasp of their possibilities and low risk. So it falls also on our shoulders to kind of prove that they are safe enough to work around people, and social care that have, some kind of distance to our patients, as well as the rehab, are sort of visibly safe, and they can kind of gain that kind of trust. I think it takes far more when we, the translational path, when we speak about the in vivo robots, because it's very, they're in far more proximity to the body, work on very critical sort of functions. And if something does not go right, they can be, you know, quite sort of dangerous to the patient. But I think if everyone of us work in our own fields and develop that kind of trust with patients, with doctors, that's our path forward, I think.
Thanks, Dana, for your comment. Are there other questions from the audience? If not, I have. Okay, Paul.
I'm going to ask a follow-up question because it's a really interesting one about the safety aspect, which is the principle of the robot is highlighted was that it's autonomous. So what happens if the robot goes wrong? Whose fault is it? Where does the governance lie with the action of the robot? Is it with developers? Is it with those that recommend it and essentially prescribe it? Or is it actually the robot itself? And it's a hypothetical question, but one that's going to be important in the future.
And it's not so hypothetical. It's a very good question, but with not a very clear answer. But it is not a unique thing for robots. Last week in the news we heard about this airplane that lost part of its side panel. It's the same thing. Is it the fault of the engineer that didn't take care of maintenance? Is it Boeing? Is it the air company? It's exactly the same question. So we will find out, and there are some basic rules, of course. If your car, if you have Tesla and you are on autonomous driving, and it kills someone, then it's quite obvious who is to blame. Although you were inside the car, so you could have prevented it. So it's not a typical robotic question, of course. You have to think about it, but it is not unique. So I think we can learn from other fields.
Thank you.
Other questions? I have a short question for Dana. So according to your experience, how long does it take for technologies like yours to enter the clinical practice, real practice?
Yeah, I get this question quite a lot. And the answer is long. It takes a long time. It takes a lot of stubbornness and persistence to sort of keep the path and not give up because of all the testing that needs to be done preclinically and then clinically, and to get them to the patient. So now with the robotic implants, we're prepared to kind of give it more than 5 years, but that's also assuming that funding is available at all times.
Very long time. Thank you.
The one cut here that I can add is that while we see the medical technology that we develop in all ways from very simple to very complex, we always can sort of simplify it and seek some kind of simple application that would entail a faster way to translation. So we can add a lot of complexity to the system because some conditions are really complex. But because we are the developers of these technologies, we could also start with simple applications, simple scenarios, and then pursue that clinically. And then along the future lines, we can look into more complex devices.
Increase the complexity.
But
thank you.
Anyway, it takes a long time, and that's what I wanted to demonstrate with the photo at the beginning. It's 38 years ago.
Yeah, you are right. And it's not they are not in the houses of the patients.
Yeah.
So I have thousands of questions for you, Luke, and for Hub too, but I see that the time is running out. So we have to conclude this third webinar. Thank you very much to all of you for participating in the webinar. And please remember that our next webinar will be held on the 5th of March and will be on patient and public involvement and engagement in child health technology development.
Very good.
So thank you to all the participants and to our great speakers.
Thank you. Thank you. It was really great to hear these three inspiring presentations. And thank you for sharing the advances in your research.
Thank you.
Thank you.
Thank you very much.
Thank
you,
you,
everyone. That was
Thank
fantastic
you.
presentations. Thank you.
Bye.
Bye-bye.